Hello everyone. Today we will focus on a significant intestinal pathogen that is Shigella. This bacterium is the causative agent of bacillary dysentery, which is a condition characterized by acute gastrointestinal symptoms. So let's start with its profile. Shigella is a rod-shaped bacillus that is gram negative, meaning it appears pink under the microscope, and it is a facultative anaerobe, which you can remember by imagining a tape on its nose, means it can operate with or without oxygen. Now, picture its hands and legs tied up. This tells us that Shigella is non-motile. It lacks independent movement. Furthermore, it is non-capsulated and non-sporing, so it has no extra armor. Now we need to know its known associates. So Shigella has four subspecies. Number one, Shigella dysentery, symbolized by a poop emoji. Next, Shigella flexneri, symbolized by flexed muscle, and Shigella boydii, symbolized with a boy and a D, and Shigella sonnei, symbolized by the sun with an eye. Of these, Shigella sonnei is able to withstand the most difficult condition, and it is common all over the world. However, it is Shigella flexneri that is most common in India. Now, this Shigella only infect humans and primates. It is primarily a parasite of the intestine, and it is transmitted by the fecal-oral route. So, this transmission happens from the feces of an infected person through unclean hands, contaminated food, water, and flies. And a very crucial point to remember is that it takes only 10 to 100 bacilli to cause the disease, meaning it has an extreme low infective dose. This Shigella primarily targets children and the elderly, along with those having compromised immunity. So, the infection by Shigella causes bloody diarrhea with mucus, abdominal cramps, fever, accompanied by nausea and vomiting. This Shigella usually invades the mucosa of the large intestine and gaining entry through M cell. This entry is mediated by a large virulence plasmid, which means that Shigella possesses a genetic toolkit of protein that add in its entry. It spreads through macrophages, which undergo apoptosis to spill out the bacteria. Remember, Shigella is non motile. So, how does it move? It requires the assistance of actin. It hijacks the host cell actin and polymerizes it to create a tail, allowing it to slide or rocket from cell to cell without being exposed to the immune system outside. So, the three important pathogenesis point to remember are large virulence plasmid, entry through M cell, and spread through actin polymerization. This Shigella produces toxins as well. It produces enterotoxin found predominantly in Shigella flexneri, which cause fluid loss. It also produces a cytotoxin called Shiga toxin produced by Shigella dysentery, which damage host cell directly. And it also possesses an endotoxin released by lysis, which causes inflammation and ulceration. Infection can lead to severe intestinal complications like megacolon, which mean dangerous increases in the size of large intestine, perforation and ulceration, and protrusion of the intestine from the anus, which is called rectal prolapse. Systematically, it can cause metabolic complications like hypoglycemia means low glucose, hyponatremia means low sodium, and dehydration. For laboratory diagnosis of Shigella infection, the specimen of choice is a stool sample. Shigella infection should be suspected in patients presenting with frequent small volume bloody stools, abdominal cramps, while nausea and vomiting are usually absent in some patients. The stool sample should be transported in a buffered glycerol medium to preserve the organism during transport to the laboratory. On microscopic examination of stool, the presence of white blood cell and red blood cells supports the diagnosis. However, stool culture remains the gold standard for diagnosis as it allows definitive organism identification and antimicrobial susceptibility testing. Stool samples provide a better diagnostic yield than rectal swabs, particularly when collected from the mucoid portion of the stool. Culture is performed on selective media such as deoxycholate citrate agar, xylose lysine deoxycholate agar, and Salmonella Shigella agar, which help differentiate Shigella from other enteric pathogens. Molecular diagnostic methods such as PCR can also be used to detect Shigella specific genes and are highly sensitive, allowing rapid diagnosis. Biochemical identification shows that Shigella is a non-lactose fermenter except for Shigella sonnei, which is a late lactose fermenter, and it is mannitol fermenting except for Shigella dysentery. Shigella is catalase positive with the exception of Shigella dysentery, which is a catalase negative. Now, treatment of Shigella infection. Treatment of Shigella infection depends on disease severity, patient age, and antimicrobial susceptibility. Because antimicrobial resistance among Shigella species is increasing worldwide, so antimicrobial susceptibility testing should be performed on all the Shigella isolates to guide appropriate antibiotic selection whenever treatment is indicated. Supportive therapy is the cornerstone of management. Adequate hydration is essential to compensate for fluid loss from the gastrointestinal tract. And in most cases, oral rehydration therapy is sufficient. Antimotility drugs such as loperamide or diphenhexylate should be avoided as they may prolong fever, diarrhea, and bacterial shedding. In adults with symptomatic Shigella infection, antibiotic therapy is recommended as it shortens the duration of fever and diarrhea by approximately 2 days. Whenever possible, antibiotics should be based on antimicrobial susceptibility results. In patients without risk factor for drug resistance, a fluoroquinolone is a reasonable empiric option, and in individuals at high risk for multi-drug resistant infection, empiric therapy may include a third generation cephalosporin until susceptibility results are available. Directed therapy should then be adjusted according to sensitivity testing. In children, correction of fluid and electrolyte imbalance is the mainstay of treatment. Antimotility agents should be avoided in pediatric patients because they may prolong symptom and organism excretion. Parenteral antimicrobial therapy is recommended for children with proven or suspected shigellosis who have severe toxemia, suspected bacteremia, underlying immunodeficiency, or inability to tolerate oral medications. Ceftriaxone or azithromycin is used as first line parenteral therapy in children when susceptibility is unknown. Oral therapy in children depends on local resistant patterns. Prevention measures are also very important. Frequent hand washing with soap and water, especially after using the restroom and before food preparation, is essential. Patients should avoid sexual contacts until at least 2 weeks after resolution of diarrhea and practice safe sex for several additional weeks due to the possibility of asymptomatic bacterial shedding. Thank you.